I've got my box. Good afternoon, everybody. Hope you're well. Hello, my name's Steve. I'm the Chief Exec here at CDDFT. Welcome to Team Talk this week. Thank you for taking the time to join. We'll do our usual thing. So just do a few quick updates and a couple of intros as well. And then we'll run through the questions that colleagues have asked in between Christmas and New Year, and then anything that comes up in the chat as well. So I'm just going to start off with a big thank you to colleagues. We said a little bit of this just before the Christmas break, but a huge thank you to everybody who's worked incredibly hard and under quite significant pressures over Christmas and New Year. I hope that those colleagues who were in on the days when many of us had some time off, you also got some time with your families, friends and loved ones, and managed to get a little bit of downtime. Lorraine will talk a little bit about the current pressures and what we're doing operationally across the trust to try and help manage those pressures. But I am very conscious and very aware that colleagues are working under quite significant winter pressures in all services. So a big thank you to everyone who's really pulling out the stops to try and keep patients safe and well looked after, sometimes in conditions that we would prefer neither patients to be in or our staff to have to work in. I also just want to say a big thank you to colleagues that I managed to say hello to on Christmas Day. I had a bit of a chance to pop around Darlington with some colleagues, and then UHND on New Year's Eve with Alison. And I finally managed to get out a bit more this week. So a big thank you to teams that have put up with me this week. I have learned a huge amount. I really appreciate people's feedback and candor, and it's really helpful to listen to views, ideas, challenges in the places that you work. So like a massive thank you for that. Still got a very long list, so bear with me. And I've nicked Julie Warner's office today, so I'm up at the White House to see some colleagues in SCL and our community teams up here today as well. So I won't yatter on too much, to be honest, because it'll be very boring. So what I'm going to do is ask a couple of new colleagues to introduce themselves. So Jill Hunt first, and then Jill will hand to Rob, and then Rob will hand back to Lorraine, who's going to talk a little about the ops situation. Jill and Lorraine are in the same office. We couldn't quite get the IT to work, so you'll see both of them on the screen and moving chairs and so on. Jill will do a little bit about, as a reminder, on masks, given the current pressures, and then we'll get into the questions. So with that, let me hand over to Jill first.
Thank you, Steve. Good afternoon, colleagues. My name's Jill Hunt. I'm the interim chief nurse for the organisation, and I'm absolutely delighted to be here. So happy New Year to everybody. I have worked in the trust before. I was here about 12 years ago. It's week one for me. I've already met some familiar faces, which is absolutely lovely. So I began my nurse training in 1986, so I'm actually in my 40th year. I'm immensely proud to be a nurse. And my professional identity is really important to me, as I know it is to many nurses, midwives, AHPs who'll be on the call. My most recent position has been within NHS England as a Director of Nursing in Professional and System Development. But the majority of my career has been in provider land, and I have got 5 years experience as an executive chief nurse, and I'm really pleased to be back in provider land and to be amongst colleagues. I know it's a really challenging time for us at the moment, and you know, I'm absolutely confident that together we can work to make things better for colleagues. We can work to make things better for the population that we serve. I will be out and about in the coming weeks as part of my induction, and really looking forward to meeting people, and I'm contactable by email, by phone, but as I say, I will be out and about, and looking forward to meeting colleagues. So thank you very much. So I think I'm handing over to Rob.
Yeah, thanks, Jill. Hello, everyone. My name's Rob Clark. I'm the interim Chief Finance Officer. Some of you may recognise me because I've been here, I think it's about week 8 actually, but prior to just taking over as the Chief Finance Officer, I was the Trust's Financial Improvement Director. We've had some questions, so I'm going to probably take a little bit of a question as to who all these new people are. Well, I was one of them. Financial Improvement Director was one of the things that we were asked to introduce following NHSE's enforcement undertakings. So that's why I was here, and now I've taken on the role of Chief Finance Officer. I've been a Chief Finance Officer before. I've recently returned to the NHS after taking 14 months off to travel the world, which I'll happily bore you about if anyone wants to come and speak to me about it. I'll tell you where I've been. My favourite country that I visited was Peru. I did not meet Paddington Bear, but it was very good for many other reasons, but I can tell you all about it. But prior to that, I was the Chief Finance Officer of Homerton in London. I will also bore you about the Homerton because I can't stop mentioning all the good things that they did and do. They were a community health provider. They were a very good integrated care trust. They had one of the best A&E performances in the country, and they were delivering on their RTT as well. So I'm not saying I know all about all of that, and I'm not saying they were the best in the country, but I do apologise if I reference them a lot. I'm handing back to Steve, I think. Oh no, Lorraine. Knew I'd get it wrong.
Sorry, thank you, Rob. And you'd not mentioned to me the ED performance and RTT, so I might be coming to pick your brains. Thank you. Steve said a thank you to everyone at the beginning of the call about the current pressures within the organisation. Probably just wanted to echo that initially. It has been extremely challenged. I think between Christmas and New Year, there was a significant amount of planning went in to prepare for that winter surge, and we managed it really well. The surge post New Year has been significantly harder than that challenge between Christmas and New Year, but huge appreciation to everyone, particularly yesterday. We made significant moves around the organisation from an additional bed capacity perspective, but also to move wards between specialties. So we now have a ward that is usually a surgical ward at DMH site is ward 32, that is now currently medicine. We have ward 17 at UHND, that is usually again a surgical footprint, that is now a medicine footprint. In addition to that, we have an additional bay on ward 31, and we've got additional beds within the day surgery unit. All of that was put in place during working hours yesterday, so hugely grateful to everybody and everyone's teams that were involved from an SCL perspective, estates, porter and domestics, but also clearly from an operational team, and that is right across the board with medical, nursing and operational staff, so particularly grateful. We've had some significant ambulance delays, which clearly some of that additional capacity should support, but it's just a big plea. Please help organisational flow through the sites and continue with the efforts with the teams. Thank you. And I think I'm handing back to Jill around masks.
Thank you, Lorraine. Just wanted to give colleagues a bit of an update on universal mask wearing in the context of flu and other respiratory illnesses. As colleagues will be aware, there is a national risk assessment tool that identifies areas that universal mask wearing is recommended, and that work was undertaken, has previously been undertaken. We've had some questions around we are absolutely seeing a decline in respiratory illnesses and flu, but actually what we don't know is if we will see an increase in response to people socialising over the festive period. So I guess in summary, it's too soon to stand that down now. So we just wanted to give a reminder to colleagues that universal mask wearing for staff remains policy within the organisation in the following areas, the high risk areas. So that's our emergency departments, SDEC, frailty, paediatric assessment, urgent treatment centres, respiratory wards on both sites, and our chemotherapy day unit and haematology ward at DMH. in terms of that timeline, we'll probably be able to reassess that position towards the end of January. So as I say, just a reminder to colleagues, and in response to some questions that we've had about when we might be able to step down, but the feeling is it's too soon at the moment. Thank you.
We handing over to question and answers, Steve?
I think we are, yes.
We are.
So it's like the you two will look like the Ant and Dec of CDDFT. But yes, I think we'll do the questions, Lorraine.
Okay, the first question was around clinical engineering, and I think Rob has gratefully said he will pick this up in Alison's absence. So Rob, probably over to you on the clinical engineering question, if that's okay.
Yeah, thank you. Just to remind people, we were asked about whether we can implement a more stringent receipts and distribution system from clinical engineering around devices and parts that go missing. In short answer, we're already on top of this. So we've recently approved a business case that will allow us to implement a tagging system, so an asset tagging system. So that's going to be rolled out very soon. It's going to start in sort of the high value areas, of which obviously where we want to make sure we're not losing or damaging kit, so we keep on top of that, and then that'll be rolled out across the rest of the trust. So that's on its way. Keep an eye out for it. That should allow us to know exactly where all our assets are at any one time, and as we say, hopefully make sure that the receipt and distribution system is better controlled.
Thanks, Rob. The next question was a bit around the transparency of recruitment processes with some of the additional interim posts. So Steve, I didn't know whether you wanted to pick this one up.
Yeah, very happy to. So a colleague has, one of the questions they've asked is saying that I think colleagues are appreciative that we're trying to be transparent and open with colleagues, but have asked how that sort of sits with some of the appointments that we've made recently, which haven't been advertised in the usual sort of way. So I think it's a completely fair point to raise, and maybe just to sort of cover it off in a couple of ways. The first is to say that because we've had some relatively short notice changes, we haven't in particularly critical roles at the same time as we've committed with NHS England to strengthen our board and exec team leadership. We haven't had the opportunity or time to do a standard recruitment process, and so we have made appointments. So Jill and Rob are two of those colleagues. They're great colleagues, but we didn't run a normal process. I think the important thing to emphasise is that's not the way that we will do the majority of our recruitment at all. What we have done is engage with our external stakeholders, so the ICB and NHS England, as we've made interim appointments, and they have had an interview with some of our non-exec directors and with myself, but that people are absolutely right to say they weren't advertised. They are by the very way that we've described, they're interim appointments, and we will advertise the substantive posts in due course, and we'll recruit in absolutely the normal way, which will be an open advert, and then sort of a couple of stakeholder panels and a final interview panel. And that's exactly what we've done for the Deputy Chief Exec role, which closed yesterday, I think, and we will interview on the 22nd or 3rd with that model of a couple of stakeholder panels and a final interview panel. So I hope that answers the question. As I say, it's a perfectly reasonable, good question to ask, and hopefully that explains why we've done what we've done, and more importantly, what we'll do about substantive recruitment going forward.
Thanks, Steve. There's a couple of comments in the chat, particularly on the update that Jill gave in masks. We'll need to take that away and have a look and come back to everyone. So Jill will pick that up next time if that's okay. There was a couple of questions around Christmas lunch and Christmas gifts. Rob's going to pick this up. And I also wanted to just ask Rob if you can respond to a specific query from a lady in the chat around cell including enteral feeding, or whether or not actually from a clinical engineering perspective would have to come back, because it is really Alison's team rather than Rob. But Rob, I didn't know whether you want to give a bit of an update on the Christmas lunch, please.
I can definitely give an update on the Christmas lunch, and the other one I think we'll have to take away and come back on if that's okay. So I used to run clinical engineering in my last trust, but yeah, I definitely don't know the answer to that one, I'm afraid. So Christmas dinner, I think they're giving all the difficult questions to the new boy. So we had a couple of questions about Christmas dinner, Christmas bonuses and Christmas gifts and so forth. And I think the predominant feeling is that prior to COVID, we used to offer Christmas dinners for people, and why are we no longer doing that? So I think that in short, the answer is we are doing things around Christmas. So we provide free Christmas meals to staff working on Christmas Eve and Boxing Day. I think Christmas Day, Christmas Eve and Boxing Day. So if you didn't manage to get that, it's a voucher system. I've been told it was well advertised, and the SCL colleagues were out and about offering those vouchers. So if you didn't manage to get one, please let us know, and we'll make sure that you can get that going forward, and what we can do to improve access to that. We also ran the 12-day of Christmas raffle. Again, if you didn't see that, please let us know. We can try and get that better communicated. But effectively, every day people were winning prizes. So that was part of our Christmas offer this year. And one of the things that I think, as I say, I used to work in a community trust, is that it's really difficult sometimes to get around our community staff as well. So I think we've picked up from that we must do better. So I've shared some ideas with Gillian on how we might do that going forward. I think one of the things we've also had is that previously the charity have funded Christmas dinners. And as such, we need to revisit that. The charity, we need to be better at raising funds. So I would also put back out to people, if anyone's got any ideas of how we can improve our fundraising efforts for the charity, please let us know. We've been a bit quiet on that front recently, and I think we are recognising that we need to do more. But at the moment, we just do not have the funds within the charity to fund that. So just to say, in conclusion, we have offered free lunches for people working around Christmas. We do have some Christmas offer, but we are open to hearing about how we might improve upon that, especially for community-based staff as well.
Thanks, Rob. The next question that came in was around the community hospital site distribution and the alignment of clinics for staff and travelling around quite a lot. It's quite difficult to answer that one without knowing the specific area of work, I'm afraid. So if the individual who's raised it is willing to meet, I'm more than happy. Just drop me an email and we can catch up, and we can try and get you a little bit more information and actually look if we can do something to improve that. Clearly what we don't want is individuals spending 1 or 2 hours travelling around the County Durham area if there's a better way that we can work. So if the individual who raised that doesn't mind, please drop me a note and I'll put some time in. We can have a chat around, actually, is there something we can do better for our colleagues working in the community sites. The next comment that came through was a bit around pay, and Rob's already highlighted that we're manoeuvring questions quite a few this week too, Rob. So the next one, Rob's also agreed to pick up just around a 4-week cycle of pay rather than once a month. So Rob, I'm not sure if you want to pick that one up.
Yeah, I'm happy to pick that up. We've had many questions in many trusts I've worked around this. And we do have some capability to help people with this, which I'll come back to. But one of the things I wanted just to describe is the principles of how we get paid. So the way we get our money from the Department of Health and NHS England is we are paid on a monthly basis. So it makes it very, very hard to pay outside of that cycle. So simply because we wouldn't have the cash at the appropriate periods of time to pay on a more regular basis. So the question asked in particular whether we could pay on a 4-weekly rolling basis. So that's the main reason we can't, simply because at times of the year we would not have the cash to be able to pay that. Also, it's very difficult to administer that for staff because some staff would like it on a 4-weekly basis, and some staff wouldn't. Some staff prefer to receive it on a monthly basis because that's how they pay bills, they pay their mortgages and so forth. So no other trusts run any other different system at the moment, as I say, so we will struggle to do that. However, recognising that our staff sometimes have struggles with meeting payment timetables, pay their bills and so forth, we do, through our health and wellbeing pages, which we'll share with you all as a reminder, have options for staff to receive payments outside of the normal payment run. There's a process through the Employee Assistance Programme with which you can follow to do that. And that's, we're definitely flagging that because we appreciate that there's a long time between payment periods between December and January. January can definitely feel like a long month. So if anyone's struggling, we really encourage you to take a look at those pages. There is support and help and advice available to you. So please do access them. Please do not suffer alone and reach out and get that support.
Thanks, Rob. The last question that had come in between meetings was around the length of time for Teams meetings. Steve's kindly going to pick this one up, and he's also going to pick up the query in the chat around the Aubrey report. I'm quite curious as to how Steve responds, because I've tried this, and people that work quite closely with me will know that I fail quite miserably to try and run a meeting for 50 minutes rather than an hour. But Steve, I wasn't sure if you wanted to respond to this one and the one that's coming through the chat and the Aubrey report, please.
Yeah, can do. I didn't know you were chucking that one to me, but that's fine. So the question was whether we could sort of set a policy that Teams meetings were 50 minutes rather than an hour, so that colleagues got a bit of time, particularly where they had a bunch of Teams meetings back to back. So I think I am similar to Lorraine. I struggle to chair a meeting to time. So I mean, honestly, I think this is something for teams to work through themselves. I don't think it's the right thing for us to set a policy organisationally on. I would encourage people to talk to each other and agree the length of meetings. I think it is important to make sure that you get a break. It is important, if you've got back-to-back Teams meetings, to get up, move around, rehydrate, do fluid balance in and out, as it were. I think that it honestly is for teams to try and agree how best to do that. So that's probably not a very good answer to the question, but it's up to you guys to, as a team, sort out how you want to structure your meetings and your days, really. And you should, feel free to make sure that in a discussion you say, look, I'm going to pop off at 10 minutes before the meeting or 5 minutes before the meeting finishes, if that's okay, to get a break. And I'm sure people can juggle around with that. So Robin's question in the chat, which I can now see, I couldn't find the questions a minute ago, but about the findings on risk management and as importantly, mitigation. So just to say, as a reminder, we published our response to the Aubrey report at our board meeting in November, in a document titled Safe, Effective and Accountable. So that sets out what we're going to do across all of the recommendations over the different sort of time periods. Very specifically on risk, this is something that colleagues have been doing quite a lot of work on. And we've got a discussion on the 15th, so next week actually, as this sort of collective leadership team to talk through the proposals. So that is going to include making the systems clearer and more consistent across the trust, so that we have colleagues able to put risks on the risk register at a ward and department level, at a service level, care group, and then exec and board and so on. There'll be a much more structured set of arrangements about how those risks should be kind of assessed and scored. That's important because it helps calibrate and make sure we're assessing risk in the same way. It also means that we can have a much more structured process about when a risk is at a certain level, it moves through the different layers of the organisation for visibility and oversight. It'll be common for some bits of our organisation that already do this, but it'll be different for others. And I know that many specialties don't have their own risk registers, which is something we need and want to correct. Part of that is also about trying to make sure risks are identified and managed as close to where services, whatever those services are delivered. The other piece of work that's ongoing but is not concluded is firstly to assess or to determine our risk appetite. That's important because it drives how we prioritise. That will end up being a board discussion. So we'll need to do that in due course, but we're going to try and set out our risk appetites and also what we're prepared to tolerate, because sometimes it's not possible to eliminate all risk. And again, that will help prioritisation, because it's not always possible to do everything at once. And then the final bit, just to say, again, which is not completed by any stretch of the imagination, but all of the risk registers are being reviewed. Margaret Kitchen, who's with us as board advisor, has been doing a lot of work with us on that. It's also going to review the risks rather than our advisors, and then we'll have a much more structured process of doing that on a regular basis. I think the point that Robin's made, which I'll just say while I've got the mic, is putting things on the risk register is very important. It's much more important to then do something about that risk. Sometimes that will include accepting the risk, but in many cases it needs to lead to change or action. And one of the issues that as I say we've got at the moment is lots of the risks have been on the risk register for a very long time, and so we need to clear all of that up and make sure that we've acted on the things that we want to change. So sorry, that was a much longer answer than you probably wanted, Robin, but that's what we're doing specifically on risk at the moment.
Thanks, Steve. There's a couple of comments within the chat actually around some ideas on how to do the team sessions, perhaps for less than on the hour, and around face-to-face meetings during lunchtime. So there's a couple of good comments in the chat from areas locally on how we might be able to do that, or how you might be able to do that within your own teams. There is a question around cyber risk and the whether or not that will be included in our risk appetite. I can probably say yes.
It will.
That does include.
Yes.
Yeah.
Yeah.
Does include
cyber security, and yeah, absolutely.
I think that's it for this week. I don't think there's any other questions or comments in the chat for us to pick up, but from myself and from Jill, huge thank you again to everyone for the efforts, particularly this week, because it is really precious. So thank you, and back to yourself, Steve. That's okay.
Well, that's teed up very nicely. All I need to do then is say a big thank you to colleagues for joining. Thanks for your questions, both in advance and in the chat. And thank you to Lorraine for fielding all the questions and facilitating all of that dead well. I will also look at the instructions on how you set Teams meetings to be 5 minutes less. I'll probably still run over. Anyway, I hope colleagues have a really good rest of the day, good rest of the week, and we'll see you back next week. I think we're at the same time, same day. So look forward to seeing you then. Take care.